Good morning, Dr. Priya. I am so excited to have you on this morning. I appreciate you coming on super early in the morning for you. So welcome. I'm happy to
Thank
have you
you.
here.
Thank you so much. I'm happy to be here.
So start by telling us a little bit about yourself and how you transitioned more from general dentistry and really focused into the TMD space.
Yes. Well, I have been practicing general dentistry for probably like 11 years. So I graduated in 2007 and I was practicing for a while before I met my mentor, my TMJ mentor. And I met him kind of on a whim. I walked into his wife's jewelry store, which is so random. And her and I are both very, I guess, extroverted people. And so we started talking, and she was telling me what her husband was doing. She's like, oh, well, my husband's a dentist and he stopped doing general dentistry like almost 30 years ago, and he just does TMJ work. And I said, oh, well, that's interesting. And so I left the store. I had left a necklace there to be repaired. And I left the store and I called my husband. And my husband's a general dentist. And I said, hey, like, I just met Dr. Arthur Parker's wife. And he said, oh my gosh, Dr. Parker, he's the TMJ guy in the area. And the reason I didn't know that yet is because I had just had two babies, one right after another, and we were new to the area.
Mhm.
So I wasn't working yet. I was not familiar with the dental community, and my husband knew that name. And he said, that's who I send all my TMJ patients to. And I said, well, I'm kind of interested in just like shadowing and observing and seeing what he does. Like that was sort of my goal, because for my 11 years of practice up to that point, I had seen people come in pain. They couldn't open their mouths, and I didn't even know what to do for them. So I was very just sort of at a loss for how can I help these people. And I thought maybe if I go shadow him, I can see what he's doing. And, if there's anything I can do to ease these people's pain in my general dentistry practice, great. And then when I went there and observed the first day, I was hooked, because everybody that came in was just basically, there were two patients that day that told me that Dr. Parker saved their lives. There were other people that were just like, I don't have headaches anymore. I don't have jaw pain anymore. I can open my mouth. I can live my life again. And I just thought, what is he doing? And I observed some of his exams too. And they were just so different from how we're taught to do an examination in dental school, because it is different. And I was just hooked. And so I remember that, I think it was that day or the next time I shadowed, I took Dr. Parker to lunch and I just said, I think I want to do this. And so I'd love to like work with you, and maybe we can figure out some arrangement. And we just got along so well. And one thing led to another. And to fast forward to this year, and I bought the practice at the beginning of the year.
Oh, awesome.
Yeah, it's great. And then Dr. Parker retired, and he's still on in the role of like my consultant and a mentor. Thank goodness, because I adore him. He's wonderful. And so that's kind of it. That's the long and short of it. And so I'm doing only TMJ work now. We don't do any general dentistry here. And we recently moved from Portland, Oregon to Vancouver, Washington, which is just 10 miles north of the border. So yeah, that's kind of where I am.
That's so awesome, because I know, I feel like TMD patients, they're like this complex pool of patients who kind of get bounced around from provider to provider. Like nobody really knows what to do, how to handle them. Some docs like don't even want to touch them. Then you know what I mean? And they end up just feeling like, what am I going to do? Like I'm in so much pain. It's just how I'm going to live my life. So we need more people like you. Like I'm thinking like in our area, and I don't even think we have any like specific TMJ, TMD type specialists. So,
right.
Your patients are just so lucky to have you, and just the profession in general to be able to learn from you and, your techniques. And I love that you put all your stuff out there, like your YouTube channel. That's so amazing for not only patients, but for professionals, because it just kind of helps patients find out that yes, something can be done. I don't have to live my life in pain. And for professionals to maybe be like, okay, there is more to this. It's not just what I learned in dental school. There is this piece of the puzzle that's, kind of missing. And hopefully they have that same passion that you did to kind of find their own mentor, whether it be you or whoever, and be able to treat this patient population. So thank you for all your work that you do. We're very, very lucky to have you.
Oh, thank you for saying that. Yeah, the YouTube channel, I started it on a whim in August of 2020, thinking I'll just put some information out there for patients. And then I mean, it's just been amazing. Like, I mean, obviously I don't have like a million subscribers, but the subscribers that I do have and the
Mhm.
population I've been able to help and serve it's been amazing. So I'm really, really grateful that it's grown. But thank you for
Yeah.
your kind words.
Absolutely. So tell us a little bit. I mean, a lot of the listeners that we have are in, the myofunctional therapy world, dental world. But tell us a little bit about the muscles that are specifically involved with TMD for anybody that might not really know.
Yeah, so there are some main muscles, and so the masseter is one of them. That's the biggest chewing muscle basically that we have. And the masseter can really, really generate a lot of force when we're clenching or grinding. So clenching and grinding, those forces can be 80 to 100 times more than chewing, or even more than that. So imagine taking like hard candy, a Jolly Rancher, and breaking it in half. Multiply that by 80 or 100 or more. And
Wow.
that's the kind of force that we can generate by recruiting a lot of different muscles, not just the masseter, but that's a big player.
Mm-hmm.
Um, there's the temporalis muscle, which is the big fan-shaped one right at our temples. So a lot of people that have tension headaches or like kind of those band of headaches
Mm-hmm.
across this way, that temporalis is usually playing a role. It's just hyperactive. And then there's a couple of muscles that you can reach from inside the mouth. And one is called the medial pterygoid, and then the other one is the lateral pterygoid. Now, there are some people that believe that you cannot reach the lateral pterygoid from inside the mouth. And then there are some people that believe you can, and I'm in that camp. So I'm not trying to open up an argument about that with anybody, but that's kind of where I stand on it. But those are key players, especially the lateral pterygoid. And when that muscle goes into spasm or becomes dysfunctional, it can wreak havoc. It can refer pain into teeth, into the ear, behind the eye, headaches, jaw pain. I mean, that muscle is about the size of the end of my pinky, but
Wow.
it is fierce, little but fierce. So those are kind of the four main muscles of like the head. And
Mhm.
then of course there's all the like neck muscles, the SCM, this big guy right here, is a big player. It actually attaches to the mastoid process, which is part of the temporal bone, which is part of the temporal mandibular joint, the jaw joint. So there's a lot of muscles actually that really can play a role in exacerbating TMJ issues, but those are some of the main ones.
Do you think that there's some patients out there that get, misdiagnosed? Maybe a root canal is recommended or something of some kind of dental treatment where they think that the pain is coming from this tooth and they treat it to only find that the pain is still there.
Yes. So we unfortunately we see that a lot. And the good thing is that endodontists have have an awareness of this, right?
Mhm.
And so we do definitely have some endodontists that are like, this is not from your tooth. You need to go see a TMJ person. But of course, in every practice, like mistakes are made or misdiagnoses are made. And so, yes, many of my patients have been on quite a journey. They've had root canals, multiple root canals. They've had multiple teeth extracted. Um, and it's just unfortunate until they finally make their way to our office and figure out, what, it was dysfunctional muscles all this time that were referring pain into the teeth. And so it can be really tricky because even I'm confused sometimes, like,
Right.
wait, maybe it is a tooth. And and so I get both sides of it. It can
Right.
be a difficult thing to diagnose correctly. Yes.
Now let's talk about the whole clenching grinding thing. How much, so I'm a dental hygienist, that's my background. And of course, I remember in hygiene school when I was, practicing clinically as a hygienist, we made night guards for everybody, as a lot of general offices do before they really learn about airway and understanding why patients might be clenching and grinding. But there has to be, for some patients, like once we rule out airway, that stress does play
Yeah, sure.
into it. So can you just talk a little bit on that? I mean, of course, I want to talk about the whole airway protective mechanism behind clenching and grinding, but also just talking about how stress can play a role into that.
Oh, yeah, sure. I mean, we've seen stress play a role just in the past 2 years with the pandemic, the elections. I mean, there's been a lot, like the racial injustice. I mean, there's just
Mhm.
been one thing after another after another.
Right.
And so I've seen so many people come in with their jaw actually locked closed. And I asked Dr. Parker, my mentor, who, I mean, he just retired in September. So he was working since the pandemic started
Mhm.
up until recently. And he said that the number of people that came in with their jaw locked closed, very painful condition where you can barely open more than two finger widths. He said that the number of patients we've seen with their jaw locked closed has been more than in that span of time than he's seen it like in that span of time in his career. Wow. So definitely we've seen a huge increase. And what stress will do is it activates the reticular activating system in our brains. And that's like, once that system is activated, we instinctually react by, sinking our teeth into whatever's bothering us. And that action is literally clenching our teeth together or grinding them together. And a lot of us do that. And it's interesting because a lot of us do it all day. We are clenched. We're sitting like this all day long. And a lot of my patients are doing that. And so talking about that and saying, we're not really going to make progress in your treatment until you figure out your daytime clenching. Like you've got to stop. And I truly believe you can train yourself to stop during the day. I don't have a solution for nighttime yet. And so, but I have seen, pain levels turn around when people can train themselves to stop doing it all day long. And the first thing is just having an awareness, because sometimes people just say, oh yeah, I clench a little bit during the day. And then they realize, when I say, no, really keep an eye on it, or put a timer on your phone that goes off every 20 minutes, find where your teeth are. They realize they're doing it all day, not just every now and then like they thought. But yeah, stress and clenching, they go hand in hand, and we see it every single day, whether it's airway related or not.
Right. Now, how much % of that do you think is linked to like an undiagnosed airway condition or disorder?
It's hard for me to answer that question because I only see TMJ patients, right?
Okay.
So I would say that like 95% of my patients have an airway issue that's undiagnosed. In general practice, though, I saw patients who were clenching and grinding, and I'm fairly certain they didn't have an airway issue, and they didn't really have a lot of pain or dysfunction. And so for those people, it may be just more stress related. So it's hard to say, but in my practice, I would say it's a high percentage.
And what about the link between orthodontics, history of orthodontics, and TMJ?
Yeah, that's high too. And so particularly in people that have had the first premolars extracted and everything's kind of pulled back, those people have a very small airway. And I see it time and time and time again, because if you think about your upper arch and your lower arch as like a box that contains the tongue, if you extract teeth and you pull everything backwards, you're making that box smaller. Where is the tongue going to go? It's going to go in the airway. And so a lot of our patients are like petite women who have had those premolars extracted, and their airways are just teeny tiny. And I see it in the CT scan. Another population that I see a lot is patients that have had like the upper two premolars extracted, but not the lower two, or vice versa. Right. And they're left with like a mismatched set of teeth. And that's not good for the muscles or the joints either. And so I'm not blaming anybody. I had my 4 premolars extracted. I have a humongous airway. I am fortunate, right? So I'm not saying it always is linked, right? But there has to be a correlation. Especially when you take that hat box analogy into,
Yeah, it just makes sense.
Right.
And what about the effects of mouth breathing on TMJ?
Big too. So I would say the majority of my patients have low tongue posture. They are mouth breathers, and they have an airway issue. It's like all of it. And then there's a video on my YouTube channel. I believe it's called Tongue Tie, Airway, and TMJ Disorders, where I really link it all together. And I think I have a very clumsy flow chart too, but it helps illustrate my point. So, check that out. Again, I'm not promoting my YouTube channel, but it just has so much information. So, but yeah, I definitely see a link and a correlation with the mouth breathing, the low tongue posture, the small airway, and then TMJ problems.
Now, do you think that the tongue posture, the tongue being up in the palate, aids in stability for the jaw joints? Can you talk a little bit about that, and why, like, once the mouth opens, we know that then our jaw is going to fall down and back. And that tongue posture usually drops. Like I know for me as a myofunctional therapist, it's you really never find somebody with an open mouth posture that has good tongue posture. Like it doesn't even feel right to have your mouth open and your tongue resting where it should be, right? It just doesn't, the two don't ever go together. So kind of talk about how once you have that open mouth posture and that tongue posture drops, how it affects the TMJ.
Yeah. So with it's hard to say because for a lot of my patients, we actually leave the tongue posture as like kind of like a phase 2.
Okay.
Because what I tried to do is I tried to incorporate myofunctional therapy. So I got trained in it. So I could.
Oh, that's so awesome.
Yeah, no, I love it. I think it's amazing, but I have a tongue tie that has not been treated. So I can't really do it that well myself.
Right.
But not only that, but the patients that I incorporated with, their symptoms actually got worse. And it's not because of the therapy, it's because their TMJ was so severe. Right. So basically, I see the most severe of the severe. So I see patients whose jaws are locked closed, who's, and for these few patients that I tried to incorporate it, they were locked closed. And I thought, let me fix everything. I'm going to unlock your jaw. I'm going to get you out of pain. I'm going to fix your tongue posture and it's going to be awesome and you're going to love me. But there's a problem because with our TMJ work to stabilize the joints, to open the jaw, to get the muscles out of their dysfunctional state, we actually have to put the muscles in their most relaxed position and the jaw joints in their most ideal position. And when we're trying to put the muscles in their most relaxed position, incorporating myofunctional therapy, which is essentially physical therapy for the muscles of the head, neck, and jaw, and the muscles that surround and support the tongue, it's giving them a workout. So these two aren't really working together. And so what I found is my patients' pain levels went up and they regressed in treatment. So what I ended up doing is I finished the TMJ treatment and then I actually referred them to a provider that provides myofunctional therapy if they were interested in pursuing that next. So there have been a few that have done that. And they ended up much better after they got their tongue in the right position, because that can help open the airway if the tongue posture is not only low, but posterior, right? And so I don't incorporate it with my patients anymore because it backfired on me, because the two modalities of treatment are kind of contradictory for the muscles. And
that makes a lot of sense, because I had a TMJ patient come in to see me and I had referred her to a local dentist that does a lot of, orthotic treatments and things like that. And we started her myo in the beginning of her process. And that did happen. She was like, I literally can't do these exercises. Like it's hurting so much. And she felt like she couldn't do her exercises with the orthotic in, and we don't really want them to have the orthotic out. So we had to take a break. Yeah. Now, what do you think? I know this is hard to say because it's like by patient, but what's the average time a patient would typically be in orthotic treatment? Like when would you start to incorporate the myo?
Right. So I wouldn't incorporate it until I release them from treatment, but I try to get my patients in and out of treatment within 4 to 6 months, depending on the severity of the case. So I don't have them for years and years and years at a time. So I feel like most people are willing to phase it out because it's going to be better for them, especially pain wise. Oh yeah. So that's typically what I do.
And then can you explain to us, what does it look like when a patient comes to see you? Their typical treatment, is it orthotic right away? Are they in some kind of splint therapy first? Yeah. How does that work?
Yeah. So, when I first see a patient, I first evaluate them and we diagnose them, and we look at our cases based upon degree of difficulty with 4 levels, 4 being the highest. And that's like a locked jaw where you can't open much.
Right.
Level 1 is more just like an occasional noise in the joint or occasional headaches, and then everything in between. So based on that is how we sort of base our treatment. But most patients get a daytime orthotic and a nighttime orthotic. Okay. With the goal of tapering off of the daytime one within 12 to 16 weeks. The daytime one, we also ask our patients to take it out when they eat or drink. So a lot of dentists won't, or a lot of TMJ dentists won't do it this way. They will make one orthotic that the patient wears 24/7, even when they eat.
Interesting.
The difference is that we are trying very, very, very hard not to change the patient's bite. Because if you're holding the jaw in a different position 24 hours a day, 7 days a week, the jaw can start to adapt to that position, which makes it so that the teeth don't line up anymore.
Right.
So some TMJ dentists tell their patients to anticipate that from the beginning. They say phase 1 is orthotic therapy, your bite will change, and phase 2 is restoring the bite to that changed position. By the end of everything, you don't need orthotics anymore, and you're good to live your pain-free life. And that's one way of doing it, which is great. Another way of doing it, which is what we do, is we try very hard not to change the bite. So we're not committing the patients to phase 2 treatment. And then we tell all our patients to wear the nighttime orthotic kind of forever. So that means if it breaks, if they lose it, if their dog eats it, they need to come back for an orthotic. So that's kind of the trade-off. It's like, you know, and so I don't know what's better. Some people do not want to go through orthodontia again. They don't want to go through full mouth reconstruction, getting crowns on every tooth to make their new bite match where the muscles and joints are happy. And so that's kind of how we do things. That's very different from how most TMJ dentists do things. And I'm not saying one way is right or wrong.
But I'm sure that the patients appreciate that you're getting them out of pain, but not forcing them into this other treatment that's going to take even longer. That maybe, like you said, some patients just, they're not interested. They know they want to get out of pain, but they don't want to go through orthodontics again. But at least, you know, I think I'm sure patients really appreciate the way that you treatment plan like that.
I hope so. Yeah. I mean, I think by the time they get here, it's like, I'm the only TMJ person around, or they've gotten a treatment plan from other people, and they're just so relieved to just, you know, be out of pain and back in function with their joints. But yeah, I hope they do appreciate it.
Now, a lot of your patients that you see, are a lot of them in traditional night guards or history of traditional night guards for like years and years and years?
Some of them, yeah. Some of them are like, well, I've ground my teeth for years and I've always had a night guard. Or some people just say, you know, I started having pain and then I got a night guard and it made everything worse. Seen that too. Yeah. So yeah, I mean, some people have experience with them and some people have none at all. Like, I've never had any problems and now my jaw is popping and it's hurting. What can you do for me? So I see the range.
Right. Now, what is your take on traditional night guards and its effect on airway, on changing the bite? What do you think?
Yeah, so traditional night guards, and I'm going to define what traditional night guard is first for anyone that may be watching or listening. So traditional night guard, the way we're taught to make them in dental school is we take impressions and then we basically make a piece of plastic that replicates the habitual bite of the patient. So we're not changing the relationship of the upper arch to the lower arch at all. We're keeping it the same and putting plastic in between there to protect the teeth from the forces of clenching or grinding. So that's kind of a traditional night guard. And that can be great for people that really don't have any muscle or joint dysfunction. It can work awesome. But for people that have muscle and joint dysfunction, oftentimes that type of night guard will backfire because the root of the problem is the relationship of the upper arch to the lower arch. And that relationship is dysfunctional. And if you're just replicating it and giving them more leverage to clench against, it's going to make things worse. And so, for example, we had a patient that came in to see us and he said that his jaw had always clicked, but recently it was getting worse and it was clicking and catching and kind of getting stuck where he'd have to like maneuver it and it was painful. And so we basically said, you know, where it sounds like it's leading is that your jaw is going to lock and you're not going to be able to maneuver it anymore. And it's going to get more painful. So this is what we do. And we explain that we make orthotics where we measure where the muscles are relaxed and the joints are aligned. And we build the orthotics to hold the jaw in a very specific position rather than replicating your position that you already have. And when we do that, good things tend to happen. The joints stabilize so you're not catching anymore and the muscles get a chance to relax and breathe so you're not in pain anymore. And so I don't know where the miscommunication was. Maybe I didn't explain it well enough, but he thought that that was the same as a dental night guard. So he just, because it's cheaper, he went back to his dentist and he told me this. He said, I did it because it's cheaper. So he went back to so I'm not putting words in his mouth or anything, but he got a traditional night guard and that actually made him lock. He wore it one night and he woke up locked and he could not get his jaw unlocked. And then he came back to us. So suddenly his degree of difficulty in treatment jumped from like what we would call a level 3 to a level 4, because now he's locked.
Right.
And it's way harder to treat a locked jaw than an unstable joint. And so basically, he was like, why? Like, I did what you told me to do. And I said, you didn't do what I told you to do. Like, let me explain again, And so for him, a night guard was disastrous.
Right.
But for somebody who doesn't have that problem, who just knows that they grind their teeth, they have no pain, they have no clicking or popping, a night guard can be a savior, because now that night guard is getting beat up and it's cracking instead of the teeth cracking.
Right.
So that's the big difference. I hope I explained that okay.
And then on the topic of unlocking the jaw, and I'm sure, I don't know if this is going to be an easy question or probably not, but how can you explain to patients how to unlock their own jaw? Like, do you teach that?
There's no way to do it on yourself. I wish I could. It's interesting that you asked, because I'm making a video that's literally called How I Unlock the Locked Jaw, Jaw Locked Closed. And so there's no way that I know of to do it successfully at home. And even the way that we do it, we don't have 100% success rate. And this is all I do all day. We have like a 90% success rate because it is so difficult to treat. So the way that we do it is we make the orthotics, but to do the orthotics, you have to take impressions.
Right.
Impressions you have to be able to open. And so some people are locked to the point where they can open enough for us to get trays in there. Other people are not. So those people, what we do is we actually do a very specific muscle release outside at the base of the skull and inside the mouth. And then we actually do a very specific, very technique sensitive jaw manipulation that you can't do on yourself. It has to be somebody, manually manipulating your jaw from the outside to encourage it to unlock, or to even just get it open enough for impressions. And then once we get the impressions, we can make the orthotics that hold the jaw in a more stable position. But even then, it doesn't unlock right away. It's a several week long process. So it's not like a chiropractic adjustment where that you could put something back in alignment. And even those can slip back out, right? But it is a slow process. And usually what people notice is, rather than suddenly they can open big, it's slowly they can open a little bit more. Their joint will start clicking and popping again. Because typically it's clicking and popping, then it locks. It doesn't click and pop anymore. And then as we unlock it, it clicks and pops. So it goes through the reverse process. So it's a 4 to 6 month process. I wish I had a way to teach people how to do it at home.
Now, what are some techniques or like little massages that patients can do on themselves to help, with pain in those major muscle groups that when I asked you about in the beginning, like the temporalis and the masseter, the FCM, are there certain like massage techniques that you teach patients to do on themselves?
Definitely. And so there's one for the masseter that I really like that goes parallel to the fibers of it, because the fibers run this way, up and down on our face. And then there's one that goes perpendicular to those fibers. So you're really getting that muscle from a couple different angles. And so the easiest one, and you can do this when you're at work, when you're at home, sitting in front of the computer, whatever it may be, but you take your middle knuckles here.
Okay.
And you just place them right underneath your cheekbone. And then you put pressure inward as much as you can handle. And then you slowly run all the way down to the angle of your jaw here.
Oh, that feels good.
Oh, it feels amazing. It feels amazing.
Wow.
That one I love. And a lot of people will see jaw pain and headaches go down if they're doing that 3 or 4 times a day. And you can run kind of that length 3 to 4 times as well.
Okay.
And then the second one for that same masseter muscle is you take your thumb and your pointer finger and you actually go inside your mouth. So you go, you open big and you go as far back till you hit bone. So you'll feel that bone. And then with your thumb, you're actually going to grab on the outside, right underneath your cheekbone and right in front of your ear, basically. And then pinch a little and slowly come forward. Pinch as much as it can handle, because really that muscle can handle a lot. And then you slowly come forward, especially with your thumb. You can kind of leave your pointer finger anchored. And then when you do it again, go a little lower. Grab lower with your thumb and your pointer. And then you're running the whole length of that muscle.
Okay.
And that one surprisingly feels pretty good too.
Yeah. Even just that initial pinch of your
Yes.
hair. Oh, it
Uh-huh.
feels so good.
Even
Everybody's,
that
I
just
have my
works.
fingers in my mouth for anybody that's
Yeah.
just listening to this on audio as I'm talking, like, "Ah."
Yeah.
Yeah.
Right.
Last night, so I went into Invisalign. When did I start? March of last year. And I'm done with it now. I'm in my retainers, permanent retainers. I have to wear 24/7 for right now. But I, during my Invisalign, started clenching a lot when I was sleeping. And I never did before.
Mhm.
And I don't do it as much as I did when I first started my Invisalign treatment. But yet last night I was laying on the couch just watching TV. And I don't know, I just went like this because I felt a little something funny and I heard it pop. And I ended up laying like this and I was pushing right here and it did make it feel really good. But I wish I had this episode that we recorded yesterday because I would have done all these techniques. But this one that you just said,
Yeah.
and pushing right there, that's
Yeah.
exactly where my pain was.
Yes. Yes. And it's so, I mean, the masseter is just such a key player in all of this. And then another thing that probably could have helped you a lot yesterday too, is actually releasing the lateral pterygoid. And so even if you don't believe that we can reach that muscle,
We're
we
doing it.
can
Let's
reach,
do it.
yeah, we can reach the tissue around it or
Mhm,
get in close proximity to it. So I wouldn't give up on this method altogether if you just
mhm,
don't fundamentally believe what I'm telling
mhm.
you. Um, so basically for that one, you grab your pinky and for your right hand, you're going to actually release the left lateral pterygoid. So you're going to go opposite. So you're basically going to take your pinky and then the nail part is going to face your teeth and then your finger is going to face your cheek side in your
Uh-huh.
mouth. So basically you open big and get as far back and up as you can, way back between your teeth and your cheek. Now close about halfway. You're going to notice you can get in there even more. So close your mouth about halfway or even more. Close
Mhm,
almost fully. You can notice that you can get even further back, as far back and as far up as you can. It's probably going to be tender in there, but
uh-huh.
basically you're going to put some pressure on that area for 10 to 15 seconds at a time, and then kind of let go and change the angle of your finger a little bit, your pinky, but still try to stay as far back and as far up as you can. Press again, 10, 15 seconds. And that actually releases the restricted fascia, the muscle a lot. And I've seen just that on one patient. This doesn't always happen. On one patient, it got her unlocked when I did that.
Really?
Yeah,
Yeah,
so that's
that
not
felt
common.
really good. Yeah.
Yeah, so I see like 3 or 4 locked patients a week probably. And
Wow.
so I don't know the math there. That's like, I don't know, something over 100, few hundreds a year. So on one patient for that to work, it's not common at all, but it's amazing how much releasing that muscle can do.
And what about for the temporalis?
Yeah, so the temporalis attaches at the coronoid process, which is like a little bony hump on our jawbone. So it kind of starts here and then is a fan shape out there. So what I do is I take my middle knuckles and I just start right at my temples or even a little below because that's where it attaches. And then I press inward again and I just follow the shape of the muscle all the way back and I spread my fingers apart as I do. So I start like this and then I spread them apart as I press inward and go up. And that one feels really amazing too. So that's running with the fibers of the muscle. And then what you can do is also run like against them. So you can just grab your fingertips and press inwards and
Okay.
go the opposite way on that muscle. And you can even look up the anatomy of the muscle to really understand the shape of it. And then a third one that's really easy is you just take your pointer finger and your middle finger, and you go right behind the orbital bone, so that eye bone, and right above your cheekbone. There's a little indentation there.
Mhm.
And that's where a lot of tension headaches are. So just kind
Oh,
of
yeah.
rubbing that forward and backwards, clockwise, counterclockwise is super helpful as well. So the temporalis, I mean, those are the 3 that I think help people a lot. On my YouTube channel, I also say how to release this sternocleidomastoid and then the temporalis tendon insertion. So I
Okay.
go through a few more, and then I think I'm going to do a trapezius one soon because that's a huge one.
Ooh,
Yeah.
that's
So
me. That
yeah,
is
for
so me.
yeah, I need to do one of those for myself almost. So that video will be out soon, but there's quite a bit of information there. But I think the 3 that I gave you are, I have received messages from people around the world saying that those
Oh, that's
helped.
amazing.
I've received messages, yeah, saying that their jaw was unlocked because of those. And
Wow.
so I have no way to verify that, which bothers the heck out of me. I would love to see those people and see it work in person, but those can really help with pain and dysfunction. And that's so easy to do on yourself at home.
And how often do you recommend, like, do they only do these when they have a flare up? Can they do them preventatively?
Yeah, all of the above.
Okay.
Yeah, you can do it preventatively. You can do it when you have a flare up. They can only help. I've never seen these like hurt anybody.
Mhm.
And so yeah, I mean, either or.
And do you recommend moist heat in the beginning versus ice?
Heat and ice is such a tricky one because it's so different for each patient. Sometimes like ice makes it way worse and sometimes it makes it way better. So I would say experiment.
Okay.
And a lot of people say when in doubt, ice actually, rather than heat.
Okay.
I would think heat. For me, heat works really well for my neck.
Mhm.
So I love that. There's like a microwavable neck pillow
Yeah.
that, yeah, I love that thing. That's, it's amazing. So I like that personally, but I would say experiment and do whatever
Okay.
makes you feel good, do that.
Yeah, absolutely. And patient population wise, I'm assuming you see more females than males.
Mhm. Yes.
And what's the reason for that?
Yeah, so my mentor and I talk about that a lot because the majority of our patients are actually young females.
Okay.
And we believe it's simply hormones. And so
Lucky
beta,
us.
yeah, I know. We already have to like bear children. We have to do it all. But yes, it's beta estradiol and relaxin. Those two together are found, of course, in much higher levels in women than in men. But those two together are also linked to degeneration within the joint. And then within the jaw joint specifically. And then relaxin itself, it's the reason we can bear children. But what it does is it makes everything loosey-goosey. It's appropriately named relaxin, right?
Yep.
And so it loosens up the ligaments in the joint. And when those ligaments are too loose, the little disc of cartilaginous tissue can come in and out of alignment more easily. Click, pop, click, pop. And when it becomes completely out of alignment, that's when the jaw locks closed. So that ligament laxity, it can serve us well in childbirth, but it can be detrimental to the jaw joint. And so we think it's mainly because of hormones. And
And what
that's,
about, do you see a lot of menopausal women or premenopausal
no,
women?
we don't. You would think that I would.
Really? Okay. Yeah.
I mean, yeah, we don't. We actually see like postmenopausal or like young women that are still, having their menstrual cycles.
Mhm.
But we don't actually see a lot of pregnant people or menopausal people. So I don't know if the change in hormones, if that's beneficial to the joint, and that's why. And there's really been no research about that. So
And what about, like, I feel like I've had a couple like 16-year-old teenage patients that have
yes,
had TMJ. What's the connection there?
I think it's just puberty.
Okay. So
Yeah, but I see a lot of that too. A lot of teenage girls are coming in with their parents. And so a lot of that. And then of course, everything's been so different with like Zoom, school, and we've even seen some young men that are just sitting in front of the computer with forward head posture rather, strain on their neck that feeds up and affects the joints, the stresses of that clenching,
So I
grinding.
thought about that because I've been out of clinical hygiene now 100% for like a year and a half. And I had much better posture when I was a hygienist working full time. I think because I was so conscious of my posture, I always wore a loop. So I couldn't, my field of vision would get blurry if I leaned over too much. And now being at the office doing myo 24/7 and being on the computer so much more than I ever was, my posture is a disaster. And it's like, Britt, practice what you preach, like, go get the body work, stretch, do yoga, do, all the things. Of course, I don't do that. But it's so interesting because as hygienists, that's where you normally hear of all the body aches, the forward posture. And I think it's worse for me now being at the computer. And then I'm sure with obviously everybody being in masks now and that, increase in mouth breathing, that has to have taken a toll on TMJ symptoms as well.
Yeah, especially my nurse patients, patients that are nurses and just wearing the mask constantly at work. And a lot of them will say, like, I hold my jaw weird behind my mask. They're like, I don't know why I do that. Or some of them hold their jaw weird to to make sure the loops are tight, the mask loop is tight enough.
Oh, yeah.
And so, yeah, I have seen jaw problems sort of go on the rise because of the mask wearing, the sitting in front of a computer all day, the forward head posture. I had a patient that came in yesterday, an older gentleman, nicest guy, and his jaw was locked closed. We've gotten him unlocked, but he's still in a lot of pain and the muscles haven't relaxed yet. He said his pain jumps from like a 1 out of 10 to a 9 out of 10 when he's lying down or when he's sitting down at work. And I said, I understand the lying down, because when you lie down, you know, the mandible drops backwards, gravity pulls it back. It, you know, it brings you out of the orthotic that's holding you in a different position. And I said, but I don't understand the sitting. And I said, are you sitting in front of a computer? Are you hunched forward? Is your head forward? He goes, yeah. And I said, that's it. And he said, yeah, I notice a difference if I sit up straight and rest my teeth in the orthotic. Pain goes down again. And I said, that's it then. So that was kind of an interesting revelation too, because I at first, he didn't tell me he was sitting in front of a computer. So I was like, why would sitting make it worse? And then when I started examining, you know, his posture, I figured it out.
Wow. Yeah. I mean, that makes total sense. I'm also thinking, like, last night when I had that TMJ pain, I was on the couch and I leaned over to one side. Oh gosh. I was like, I have to sit. Same thing. I was like, I have to sit up nice and straight. Otherwise, even if I just like relaxed more into the couch, it hurt more. So
it's so interesting.
Yeah. It's so, I mean, the work you do is just, it's so interesting. I mean, TMJ is one of the most complex things to work with. What about, like, for providers that want to find somebody like yourself? Is there a network of you guys? Is there any way for us to find you?
Well, the tricky part with TMJ is every single TMJ dentist that you meet does it a little differently, right? And that's because there's no real like TMJ specialty program, or I think there was one that was approved last year, but their method of treatment is very different from how my mentor treats. And so a lot of TMJ dentists have learned from a mentor, and all the mentors do things differently. So people will contact me and say, can you find someone in Connecticut that does it exactly the way you do it? I'm like, no, I can't.
Unless I physically get on the plane and come to Connecticut. No.
I don't. So I do belong to a study club where it's a sleep dentistry and TMJ study club. And you kind of have to prove that you are really doing that and really passionate about it to even get into the study club. So it's a very committed study club, which I love. Having said that, the majority of the people in it are sleep dentists that are starting to get into TMJ. I'm the opposite. I'm a TMJ dentist that's starting to get into sleep more. So even then, it's like, if those dentists are wonderful and they're very, very skilled, but if somebody came to me with a locked jaw, how comfortable are they treating that? So in that case, sometimes I reach out to somebody in Ohio, one of the dentists that's in that study club, like, do you feel comfortable with me sending a patient to you whose jaw is locked closed? And then they either say, yes, I've treated that before successfully, or they say, no, please don't. So I wish there was a network that people could access online, but no, there's not. And I try to do my best to make good referrals, but I'm also anxious about making them, because I had one patient that just, you know, said, why'd you refer me to that guy? He was awful. He doesn't know what he's talking about, this, and that. And it's like, I'm trying to help you. You know, so
you're not physically there. You haven't physically been treated by them. Like you've done, you know, you're, like you said, you're just trying to help. But I think, again, the network that you're creating through your social media platforms is so helpful. And if you want to tell the listeners where they can contact you on those platforms.
Yeah. And so typically what I do is I set up like a Zoom meeting first, because it's really hard to gauge from a conversation what's actually going on with that patient. But there's not enough hours in the day right now for me to accommodate everybody. So I'm doing my best. It's just really hard to make a quick referral from a quick conversation, because I've gotten in trouble for it once. So I'm very gun shy about it. So, you know, I do my best, but people can reach out. We can set up Zoom meetings and kind of go from there.
Awesome. And they can find you on your Instagram page. What's your handle? I know, is it just TMJ Doc?
It's _TMJ_Doc.
Awesome. And your YouTube channel, everybody should definitely go check that out. We will link both your Instagram page and your YouTube channel in
Thank you.
our show notes. Is there any other anything you want to leave with the listeners before we wrap things up?
Yeah, just, if you are on your own sort of TMJ journey, just, keep your hope alive because there's typically light at the end of the tunnel. It can take a lot of research and a lot of time and work for you to find that practitioner that, knows and understands what you're going through and knows how to treat you. But with study clubs like the one that I'm a part of, those practitioners are becoming easier to find, hopefully, in time. And so keep your hope alive, and there is a light at the end of the tunnel, and I'm here to help. I'm here to answer questions, and that's really it. And thank you for having me, Brittany.
Yes, thank you so much, Dr. Priya.